Welcome to the Universal Healthcare Work Group meeting number 8. 8 of 9.
Jamie, while we're still messing around with just sort of mechanics, I'm assuming that there is no meeting on next Thursday, November 5th. Is that correct?
That is correct. If you have that in your calendar, that's an old meeting invitation that was not deleted. Our next meeting is in December. Can someone help me out? Is it December 13th, 7th?
I think it's later. Hold on. I'm looking at my calendar.
Okay. Liz will come to the rescue with the December meeting date. Liz, while you're doing that, I'm going to go ahead and do our tech moment here. So bear with me. I'm going to share my screen, folks. Okay, can you give me a thumbs up if you see a PowerPoint slide that says Zoom Etiquette Workgroup members? Thank you. All right. For most of you, I know this is a repeat drill, so I will go very quickly. I know there's a few new guests with us today. So for those of you who are new, there's going to be 2 slides. One has our Zoom rules for our work group members, and then the second slide is for our members of the public who are our guests today. So work group members, I know you know this really well, so I won't spend a ton of time on it. Please keep your video cameras on if at all possible, if you have the tech and the bandwidth. It really does help enhance our collaboration and make it a lot easier for us to facilitate. Plus, we like to see your faces. But if you could keep your mics on mute until called upon to speak, that will help us minimize the background noise. I always encourage people to go to your top right-hand corner and click to gallery view. That will allow you to see as many work group members as possible on your screen. We disable the chat function for these meetings because of the large number of participants. So you are able to send a chat to our host if you are having a tech problem, but not a group chat. And finally, we always use the raise your hand to speak function to minimize talking over each other. And a reminder of how to find that, it's in the bottom center of your screen. There's a toolbar there. If you click on participants, it should pull up a new window with a raise your hand button that you can click to signal you're raising your hand. And then I will track, or your facilitators will track the order that hands go up and call on you in order. If you are participating by phone today, workgroup members, you can press *9 on your phone and it indicates that your hand is up. And finally, if all else fails, just wave your hand frantically at us and one of us will catch it, either the facilitator or one of the other team members will catch it, and we'll do our best to call on you. All right, for our members of the public, thank you as ever for taking the time to spend the afternoon with us. We really appreciate your engagement. For you, I'm going to ask that you keep your mic on mute and your video camera off. And the reason is that we have nearly 100 people participating in some of these meetings, and we need to be able to distinguish between our work group members who are speaking during the working portion of our meeting and our guests. So unless it's your time to make public comment, which I'll talk about in just a moment, please keep your video camera off. Same remarks about the view of the screen. You may want to click on gallery view so you can see most of the work group members, and the disable chat function you already know about. With respect to public comment, we're going to be starting public comment at 1:20 today at the beginning of the meeting, as we've done for the past 2. When it's time to make comment, I'll be calling on you in the order in which you signed up. When your name is called, then you can turn your video camera on by clicking the Start Video button in the lower left corner of your screen. And then you'll get a little pop-up that'll request to unmute your mic, and you can click unmute in the lower left corner of your screen. And then when your time is up, you should mute your mic and turn your camera off again. And I'll go through the more detailed public comment rules shortly. You may notice today that we are using closed captioning at the beginning of the meeting. We do have someone who's making a comment today who is living with a hearing impairment. So we're using closed captioning to make sure that person is able to participate in the public comment. We're not able to do closed captioning for the whole meeting, but we are going to be providing a Zoom transcription of the whole meeting after we're posting it to the website. So that will be available for anyone who needs it. All right, I think that's the extent of the Zoom etiquette comments. So I am going to turn it over to Michelle Needham with the Healthcare Authority. She is standing in for our chair, Sue Birch, today, who's not able to attend, and she just has a few words of welcome for you. Michelle?
Thank you. I think the unmute worked now. Thank you, Jamie. Just wanted to welcome all of the work group members today, and we're looking forward to a really lively discussion. I think the work group team has a lot of material. I know it's a little bit dense to work through in a short period of time, but we appreciate your active engagement and your continuing participation in this work group. I know it's been a long process so far, and we're rounding the corner into the last couple of meetings, so bear with us and we'll all get there together. So thank you. Looking forward to an active day.
Thank you, Michelle. Okay, so now is the time when I'm going to walk you through our meeting objectives and agenda. So again, thumbs up if you see meeting agenda on the screen. Everyone see that? Yep, okay, awesome, thank you. All right, so we have a few objectives today. First, to hear public comments as ever. And then we're gonna spend the first half of the meeting confirming the goals of universal healthcare in Washington. The second half discussing a transition plan, including next steps for universal healthcare in Washington. And then finally, we'll confirm action items and next steps. I'm going to walk you through the actual timing. We've covered our technology review and our welcome, and now I'm reviewing the agenda with you. As I said before, we're going to be doing the public comment period at 1:20, and then at 1:40, we're going to move into our breakout groups. And this first discussion is going to be about the goals of universal healthcare. And I want to just say a few words about this. The goals discussion is really intended to be a reflection of everything that the work group has discussed to date, and also serve as an entry point for our conversation later about transition steps. So the goals conversation is really affirming what you discussed, particularly at our December and February work group meetings, and also reflecting the work that's been done since then on the actuarial analyses and talking about the models. And then later, our transition conversation, which I'll talk about just in a moment, will really focus on the steps to take that we need to take regardless of which of the models the state ultimately goes with. So we had that conversation about the end goals of universal healthcare. We will take a stretch break at 2:45, just 5 minutes today, folks. I'm sorry I can't give you 10, but we have a lot to cover today. And then we'll move into our second round of breakout groups at 2:50. And this is when we talk about transition steps. We'll wrap up that at 3:55, do 5 minutes of action items and next steps, and then we will adjourn. I'm going to just briefly walk you through our decision process. This graphic should look very familiar to our work group members and members of the public who've been participating all year. So this is the point of this, is to show you where we've been, where we are, and where we're going. So believe it or not, we first met over a year ago, September 19th, 2019. And that first meeting was all about level setting and laying the foundation for our process of working together. And then we convened in December of 2019. There we really focused on diving into the problems with healthcare in Washington and our root cause analysis. And then in February, the last time we got to meet in person, we did a lot of work on articulating our assessment criteria, which is really the things that people on the work group value and what you want to see out of this universal healthcare system. April, as you know, that meeting was canceled due to coronavirus, but we reconvened again in our first digital meeting in June 2020, and there we discussed and refined the 3 draft models for universal healthcare. In August, we applied our assessment criteria to assess those 3 models of universal healthcare, and also did a little initial conversation on the actuarial analyses. September is where we started talking about the actuarial analyses and those outcomes. And we extended that conversation into our first meeting 3 weeks ago in October, because there was a lot to digest. And now here we are, we're arriving at our second October meeting. And today's the day when we discuss the end goals of universal healthcare and the transition plan. And then we get back together in December. Liz, what's that date? Were you able to track that down?
December 9th.
December
Wednesday,
9th. Okay.
Wednesday, December 9th.
Exactly a year. Okay, exactly a year from our last December meeting. And so December 9th will be reconvening, and you will have received and reviewed the draft report to the legislature on November 18th. So we're going to use that December 9th meeting to discuss your feedback and make final adjustments to the report, to the universal healthcare goals, and the transition steps as needed. So that is where we've gone. I just want to add one more note about next steps, and I'll mention it again at the end of our meeting. Optimus has actually prepared a document that provides additional background on the models, including expenditure and revenue sources. And our hope is that it'll enhance your understanding of the models. I'm going to send that out to you right after our meeting today, and I'm going to ask you to review it and provide us with any additional questions you have by next Thursday, November 5th. And then we will be, or really Optimus will be, responding to your questions in both a written document and via a recording. So we're going to move, actually we're a little ahead of schedule. We're going to move into public comment period in just a moment, but I do see a hand raised from one of our workgroup members. So I'm going to stop the share here and call on Aaron Katz. Aaron?
Thanks, Jamie. Just a question about the review of the draft report. I'm a little concerned about, all of us getting a one chunk, one time review of, what's going to be a fairly significant document. And I'm wondering if there's any way that we can get more, sort of more frequent chunks that we can review and give feedback on as a way to build out to the final report. I'm just concerned about sort of, the one shot at a review and comment. And I know we're on a tight timeline, but, this is kind of a critical stage. So I'm wondering if we can schedule in more frequent, review and comment.
Sure. Thank you, Aaron, for raising that question. I can't make any commitments right now because I do need to talk with the project team, but I will bring, they're all hearing that too, and we're actually getting together tomorrow as a follow-up. So we'll definitely take that request under consideration tomorrow and get back to you. Awesome. All right. Any other questions there? Great. Well, that bought us a few extra minutes, which means we may be able to take some additional public comments. So I'm going to briefly walk everyone through the public comment process, and then we'll do a dive into the public comments. So let me go back to sharing my screen again. All right. So folks who signed up to make a public comment received these rules for making public comment via email yesterday, so they're pretty familiar. I want to let everyone know we had 42 people sign up to make public comment today. So we anticipate that we're not going to be able to accommodate all the people who signed up to make public comment today. That's okay. If you don't get called on today, you can still submit your comment via email. The email address to submit comment is on the HCA Universal Healthcare website. And all our workgroup members receive all of the public comments, whether written or verbal. We don't weight verbal comments heavier than written ones. So please do submit your comment written if you aren't able to make a public comment today. I am going to take folks in the order that they registered. And we did close the registration for public comment on Tuesday at 5 p.m. I've also used my discretion to reduce the speaking limit, the time allocated for each speaker, to 90 seconds, so we can take some additional comments today. And I'll be strictly enforcing that time limit as ever. On your screen, there will be a timer, so you will be able to track how much time you have left. Please do, when you hit that 90 seconds, please wrap up your comment and stop speaking so that we can make sure that we can take the next speaker. Let's see, any other? Oh, yes. As a reminder, I call 3 names at a time in the order that you're going to be coming up. So first speaker, second, and third on deck. And then when your name is called to speak, please turn on your video camera and unmute your mic. you'll get a little pop-up window that'll ask you to unmute your mic, and you can unmute. And when you're done speaking, you can go ahead and turn your video camera off and mute your mic again. I'm going to share with you now. As I said, there were 42 people who signed up, so this is the order in which I'm going to be calling you today. There are 3 slides here, so bear with me. I'm just going to pause for a moment so that folks can see where they are on the slide. And our public commenters actually received this list yesterday, so you should know where you fall. So here's the next screen, commenters 21 through 40. Oh, actually, I numbered this wrong. My apologies. All right. So I'm going to go ahead and stop sharing. I'm going to put up the timer. So I'm going to call the names in the order we're going to be taking comments. Our first speaker, and please forgive me if I mispronounce your name. I always try to pronounce them correctly, but I do have some misses here. So our first commenter is going to be Sherry Rozzoli, followed by David Loud, followed by Maureen Brinklund. And Sherry, it looks like you're unmuted, so you're ready to go. I'm going to start the timer. Please start by saying your name, and then you may make your comment. Go ahead.
Hello. Good afternoon, ladies and gentlemen, and distinguished guests. I'm Sherry Rozzoli, and I'm speaking today on behalf of the Hearing Loss Association of America, and as well for the Washington State Association. Hearing help is not covered by most insurance companies nor Medicare. I'll share my personal story. At the age of 19, I was diagnosed with progressive deafness. And at that time, my world was forever altered. I did get hearing aids, which helped a lot, but the cost of the hearing aids was the equivalent of a semester of my college tuition. It was a huge financial burden to my parents. And in managing my hearing loss, I have purchased over 16 sets of hearing aids and accessories at a cost of over $50,000. I am a board trustee for the Hearing Loss Association of America, where we work tirelessly to serve consumers who have hearing loss. We have policy papers on Medicare and recommendations for insurance.
Sherry, I apologize. I did not put this on the screen in time, so I'm going to give you a few extra seconds to finish your comment.
Okay, so hearing loss is a serious condition, a major life loss that those with good hearing find difficult to understand. And by 65, 1 in 3 people have a hearing loss, and it is present in all age groups, both sexes and all races. And in Washington State, we were talking about 1 in 7 and 1 over 1 million people. So I encourage you to include hearing health care in all the insurance recommendations. Thanks so much.
Thank you. All right, next up is David Loud, followed by Maureen Brinklund, followed by Tanya Atkinson. David?
Hello, David Loud with Puget Sound Advocates for Retirement Action and Healthcare as a Human Right, Washington. COVID has inflicted the double punishment of unemployment and loss of health coverage on tens of millions. In our state, nearly 100,000 workers laid off during COVID remain uninsured as of last month. Establishing a universal public plan and delinking healthcare from employment is the most important step we can take to guarantee healthcare for all and to control healthcare costs. As Leonard Veers reminded us last time, labor is on board with universal healthcare. At the Washington State Labor Council Convention last month, delegates representing 550,000 union members adopted a universal healthcare resolution by a vote of 202 to 0. This resolution reaffirms labor's support for national Medicare for all proposals, which include a benefit package equal to or better than existing plans won by workers, and also stresses the importance of a universal plan to overcoming COVID and addressing racial inequities. We must make sure that a universal plan in our state will provide robust vision, hearing, dental, and mental health benefits so that workers now covered by employer plans will not lose anything. Thank you.
Thank you, David. Next up is Maureen Brinklund, followed by Tanya Atkinson, followed by Cindy Laws.
Hi, my name is Maureen Brinklund.
Maureen, you can go ahead and start speaking.
Oh, sorry. My name is Maureen Brinklund. And several times in the last meeting, I heard suggestions that this work group look to Cascade Care. And I'm wondering why we keep hearing about Cascade Care. This work group's option A is time and again the option the majority of participants and public commenters at these meetings say they want to see developed and implemented. Does Cascade Care bear any resemblance to option A? Cascade Care might provide some immediate relief to currently uninsured individuals in Washington state, but it's my understanding that it's not going to meet the challenges keeping costs down long-term. This work group is tasked with figuring out long-term sustainable solution. To quote the charter, this work group will study and make recommendations to the legislator on how to create, implement, maintain, and fund universal health care system that's sustainable and affordable to all Washington residents. It does concern me to hear that private meetings might be taking place between the leader of the work group and members who otherwise have not come to the open meetings. If this is so, the whole idea of this work group being a public work group and its recommendations being the result of an open meeting is highly suspect in this citizen's eyes. I urge the work group leadership to demand and display total transparency and share any discussions being held in private meetings. As a member of the League of Women Voters and a longtime Washingtonian, I value good governance in our public policy planning, and I think the public deserves nothing less. Thank you.
Thank you, Maureen. Next up is Tanya Atkinson, followed by Cindy Laws, followed by Greg Arnold.
Hi, my name is Tanya Atkinson, and I am a new clinician and do not look forward to paneling 6 different insurances for my practice. Would much more be comfortable once I become completely licensed to receiving a single universal healthcare plan. I want to mirror the comments made by earlier people about the idea that Cascadia plan, I don't understand why it has such a prevalent presence in this group. And as I was looking at the homework that we had from the last meeting, it had a presenter that outlined Cascadia plan in a way that it should have had for single healthcare. If you're going to have A and B and you only show C as the coverage that you've got a complete outline for, I feel like that's inappropriate and shows a real strong pull that this group is having to be put into to look at Cascadia plan. I don't think that I also feel like what we're talking about, the costs outlined for the, was it Octavia's, be shared with the group. I want to mirror what Aaron said about the fact that it can't just be one picture of what we're looking at costs and just say, that's it. That's what it feels like to me, is that we're looking at, this is what we have for Cascadia. This is our outline of costs, and that's it. We're not having any more back and forth conversation on what we're doing with costs and how a single payer plan can benefit that aspect. Thank you.
Thank you. Next up is Cindy Laws, followed by Greg Arnold, followed by Heidi Shore. Cindy?
Good afternoon, everyone. Thank you for this opportunity. I, as you know, work with Healthcare for All Washington and was a lobbyist on this bill. Just a reminder one more time that the Pathway Bill did not ask for status quo planning. Option C is status quo planning. And the opponents of universal health care keep insisting that it is the best way to reach people. Clearly, it is not. The pandemic has certainly shown that to be very true. People cannot get care. They're afraid to go seek care if they have symptoms, and so on and so forth. Additionally, I want to reiterate that cost sharing, the people promoting cost sharing have presented zero evidence that cost sharing does anything except exclude people from seeking care. We need to have, as the pandemic has shown, to make sure that everybody has access. Healthy people are more productive people. They work better and they're able to pay more taxes when they can work more, all of which benefits the state of Washington significantly. Again, here we are. We have in the state of Washington 2,454 COVID deaths, 886,000 people who have been infected with the virus. And again, those people who have been infected have significant costs associated with that. We must pass option A. We must move vigorously and quit it with the gamemanship regarding option C. Thank you.
Thank you, Cindy. Up next, we have Greg Arnold, followed by Heidi Shore, followed by Karen Starling.
Jamie, I think Greg Arnold, Heidi Shore, and Karen Starling are all not here, although chime in if you are.
Okay, I'll go ahead and make a note and we'll come back and check in. Next up then would be Julia Buck, followed by Debbie Hollier, followed by Kathryn Lewandowski.
Hello, my name is Julia Buck. Thank you for the opportunity to share my experience. In 1999, my mother was diagnosed with stage 3 cancer. For 2000, my father's firm changed what health insurance plans were offered. Although we were covered by the same company, my mother's cancer was declared a pre-existing condition and no longer covered. Her radiation treatment and follow-up care cost $585,000. Eventually, we were partially reimbursed for that money by the insurance company, but it took 4 years. With the overturn of the ACA a real possibility, I would like to ask that you go with option A. I lost my job and with it my insurance during COVID-19. I had to go onto my spouse's insurance. The alternative for comparable coverage would be either half of my monthly unemployment payments or a plan with a $10,000 deductible, too expensive to use. Even under my spouse's insurance, I can no longer go to any of my previous doctors, including my mental health care specialist. I am paying $358 a month to not go to the doctor. My circumstances are one of this system's best case scenarios. The medical insurance industry is a parasite on our healthcare system. Their business model conflicts with the goal of public health. I ask you to please choose option A as the only option aligned with healthy people. Thank you.
Thank you, Julia. Mia, do we see Greg or Heidi or Karen? Should I keep going?
I do not see them.
Okay, then let's move on to Debbie Hollier, followed by Kathryn Lewandowski, followed by Pamela Dalen.
Debbie, I don't think is here, but Kathryn is here.
Okay, so it'll be Kathryn Lewandowski, followed by Pamela Dalen, followed by Leah Purple.
Hi.
So Kathryn, you can start speaking whenever you're ready.
Okay, my name is Kathryn Lewandowski, and I am a registered nurse practicing here in Washington State for 30 plus years, and I'm a volunteer and on the board of Whole Washington. Thank you all for the time and energy that you have all put into this working group. I know that most of you are here for specific reasons that you could best address in our search for reforms to our healthcare system that will increase access, affordability, and improve outcomes for our Washington citizens. I'm here today to encourage all of you to re-examine your reasons for being here. This current pandemic has exposed so much of the economic waste and social injustice of our current system. We must finally correct this system of attaching a for-profit intermediary that ties our healthcare to our place of employment, a system that has not delivered any of its promises of lowering costs, improving access, or improving outcomes. We need to start using our healthcare dollars to provide care rather than continuing to devise ways of discouraging access to care for our people. Too many of us have died from this virus. Too many of us will have long-standing disability through no fault of our own. This virus has been devastating to our communities, our state, and our nation. I truly believe that in order for this working group to truly meet its goals, it will be imperative that some of you will lose. But you must remember that your losses of potential profits will in effect benefit our entire society. Your loss will save lives. decrease disability, and will give us the actual cost savings to allow our state to be able to adequately address the economic impact that this virus will have on our
Kathryn,
government, our
I need you to wrap
businesses,
up now.
and our citizens. Your loss will become a
Kathryn, thank you. Thank you. All right, let's move on. We've got Pamela Dalen, followed by Leah Perkle, followed by Joseph St. Aubin. Pamela, you can go ahead whenever you're ready. Yeah, do we have Pamela?
She is here and she's unmuted.
Pamela, are you able to speak? Okay, I'm going to make a note. We'll come back to Pamela in just a moment. Let's go with Leah Perkle,
And
followed by
Leah is
Joseph
not,
St. Aubin.
Leah's not here, but
Okay,
Joseph is.
let's go with. Okay, let's go with Joseph St. Aubin, followed by Kevin Wren, and then we'll come back to Pamela.
Hello, members of the committee. My name is Joseph St. Aubin, and I support option A. I've heard it stated in your last committee meeting that the final report from your committee is supposed to reflect different options for the legislature to consider in its deliberations. However, I believe the purpose of this committee should be to recommend a particular path forward, and by not giving preference to a specific option nullifies the effectiveness of this committee. And I request that your committee recommend option A to the legislature as the only option that the legislature should consider in its plan to provide universal health care for all Washingtonians. I also have a much longer written report that I will submit online. Thank you for your consideration.
Thank you. All right, let's take Kevin Wren, and then we'll see if we'll try Pamela Dalen again.
Thank you. My name is Kevin Wren. I am the leader of Washington Insulin for All and on the board at Healthcare for All Washington. I think it's important for us to understand this process leaves many behind, and the upcoming legislative session will as well. If meetings deciding the fate of health care are all held online and comments submitted digitally. The digital divide prevents many from not being able to have their voices heard, from rural and frontier communities who lack basic internet access to those in urban areas without the means to afford a computer or reliable internet access. Amid the pandemic, healthcare is also being delivered more and more online, which leaves too many lacking access. We have to work to remove all the barriers around the access to care, from basic cost sharing to figuring out how to best reach those without internet access. We need option A to mitigate class-based obstacles like affording internet access and cost sharing for low-income immigrants, from low-income people, immigrants, and senior housing households. Having at-home internet is often too expensive. Households earning $25,000 or lower in Seattle have the lowest internet access rates, with 21% of households reporting lack of internet access in 2018. Thank you for this opportunity.
Thank you, Kevin. All right, let's try Pamela again. Mia, is it working?
She's unmuted, but Pamela, are you able to speak?
Okay, there must be some kind of technical problem. Pamela, I'm going to ask you to please email your written comments to us, and we'll make sure the work group sees them. I'm sorry that it didn't work for you to be able to make a comment today. On my list here, it looks like we have time for at least 3 more comments. So let's take Louis Ting, followed by Dr. Ken Fabert, followed by Bonnie Morris.
I think Louis and Ken are not here.
Okay, I see Bonnie. So let's go with Bonnie Morris, followed by Aruna Bhutta, followed by Jen Nye. Bonnie, you can go ahead whenever you're ready.
Can you hear me? Hello?
Yes.
Okay.
Hello,
Hi,
we can
I'm
hear
Bonnie
you.
Morris. I'm a retired inpatient psychiatric nurse. In my long career, I've cared for countless patients who have attempted suicide or contemplated it. Sadly, many of them could have gotten help before coming to such desperate circumstances if access to mental health care had been affordable to them. I've also watched my brother in Ohio have to declare bankruptcy because of the enormous cost of medical bills not covered by his work-sponsored health insurance. His daughter, who has cerebral palsy, is wheelchair-bound and very fragile health and has needed many hospitalizations. As a member of North Seattle Progressives, I studied the problems with healthcare access and inequity in our state. I definitely recommend this group to recommend Model A without cost sharing as in their recommendation, because this choice of all options is the most equitable, efficient, least likely to cause bankruptcy, and least likely to discourage people seeking life-saving care. We need to act rapidly to start the process. People's lives, health, financial stability are more at stake than ever. Any other recommendation would be like putting a finger into a leaky dike to solve our state's healthcare problems and not a pathway to universal healthcare. Thank you.
Thank you. Next up, I have Aruna Bhutta, followed by Jen Nye, and then we'll have to end public comment period.
Good afternoon. This is Aruna Bhutta. And I would like to thank the work group members and the legislatures for passing this legislation for universal health care. And it'll be very important to consider the option A, because the options, the 5 health plans, that were kind of considered have significant amount of cost sharing as far as being able to access the primary healthcare providers or a specialist, as the case, the need may be. Also want to make sure that mental health and palliative care is also included in this important healthcare program. Please consider Model A so that people have truly, access, and the co-insurance and the premiums are not the barriers. Even though they have insurance, they can not access if there are high financial costs. Thank you for all your work, and I hope you'll consider Model A.
Thank you. Okay, final speaker today is Jen Nye.
Hi, thank you. I'm Jen Nye. Thanks for the opportunity to speak. My greatest hope for this process is not just that we choose option A, but that we acknowledge why our current system is so cruel, unsustainable, and cannot be fixed with another layer of programs. My challenge to everyone in this group is to come up with answers to these 2 questions. What service do health insurance companies provide, and what value do they add to society? I have come up with nothing. We are wasting precious time and lives by avoiding what we absolutely must do. We have to begin transitioning away from the health insurance industry because it is harmful and traumatizing. We are tired of the manufactured complexity, bureaucracy, and indefensible cost. We're tired of throwing more and more money down a well only to remain so nakedly at the mercy of a profit-motivated industry. We don't want to shop for plans. We don't want to make a gamble every year with open enrollment and pray that we guessed right. And we don't want to interact with a health insurance company every time we have a life event. Mostly, we don't want to be commodified anymore. What we want is a system that is kind. Is that a metric that we can measure? Can we have a system that offers care when we are at our most broken and most vulnerable without proving membership in a very expensive club? We must use this crisis to remake a kind and just system. Thank you.
Thank you, everyone. That concludes our public comment period again for today. Let's see here. So I see everybody on the screen again. We're going to be moving into our breakout groups momentarily. So first I'm going to ask our work group members to put your cameras back on if you can. And I'm just sending a quick note to HMA events. Bear with me just a second. Okay. My apologies. We're going to be moving into our breakout discussions now. And this first discussion group, we're going to be focusing on confirming the goals of universal health care. So you should have had an opportunity. We actually sent out the documents for this for the October 7th meeting. But as you may remember, we made a game time decision to focus that meeting instead on discussing the actuarial analyses. So we're going to devote this first half to confirming the goals of universal healthcare. As a reminder to what I said earlier, this discussion is really intended to build on what you've already discussed over the year and bring it all together, and then also set the stage for our transition discussions. So with that, we're going to move into our 3 breakout rooms. As a reminder, there's one group that's going to be staying in the main room with me and Nora, and then our other work group members are going to be moving into rooms with Betsy and Janine in one room and Liz and Jared in another room. And then we're all going to come back together for the last 15 minutes to do a report out. So we'll be together in our rooms for 50 minutes for a facilitated discussion, and then come back into the main room for report out. And we will be recording all the discussions. So members of the public, you're going to be staying in the main room with me and some of our work group members, but we'll have recordings of the other discussions posted to the website later on, so you'll be able to review those. And with that, I think New York Liz, I think we're ready to move into our breakouts. So we'll just take a quick pause here while everyone gets shuffled. Okay. Wonderful. Hi, everyone. All right, let's get started. So as I said before, the purpose of this discussion is to get your feedback on the goals of universal health care so we can include them in the final report to the legislature. And as a reminder, the draft goals that you received quite a while ago, and then also heard a presentation on for our October 7th meeting, were intended to reflect the feedback that we have received from you to date, including what we talked about in December and at our February meeting and all the actuarial analyses. My role, and so today our job is to really refine these and capture all of the viewpoints, including members who may have a different perspective on these goals. Now, my role as facilitator is to try to get feedback from all of you who want to contribute, which may as ever mean bringing the conversation back on topic if we start to veer off. We are not, as we've always said, expecting consensus on these. Instead, what we need is confirmation that we understand your feedback and we're documenting it correctly. So if someone proposes something that you don't agree with, please do use this time and opportunity to share your perspective. Even if you are a lone voice, which I know can be tricky, for the benefit of the legislature, we want to capture and document your perspective accurately. So let's see here. And then as a reminder to our members of the public, please, if you are not on the work group, please turn off your video camera. On my screen, I have 50 people, and in order for me to be able to call on work group members, I really just need to be able to see them. So if you could turn off your cameras, that would be great. Thank you. All right, so I'm going to briefly, I'm going to be oscillating a little bit because I want to be able to see your faces, but I also want to make sure I am showing, reminding you of what goals are. So let's start here. So I'm just going to put this up briefly, and then I'm going to take it down again so we can have our discussion. So as a reminder, from our work group discussions in December, we kind of synthesized all of your input into a statement that had a lot of sub-statements, but just a reminder that we synthesized this into universal healthcare means all Washington residents can access essential, effective, and appropriate healthcare services when and where they need it. And I see Dr. Tritko raising your hand. I know you have some input on this statement here. I'm going to move us to the next slide because I also want to ask a question on the next slide, and then I'll go to Dr. Tritko. So our first goal that we're going to talk about is regarding access. And the draft goal here is that we're hoping to achieve a system that provides all Washingtonians with full access to comprehensive, essential, equitable, effective, and appropriate health services that are affordable to everyone. And the question that I want to ask you first is, what should be added or adjusted, if anything, in this draft goal? We'll start there. And I see Dr. Tritko's hand. I'm going to stop sharing so I can see all of you. Dr. Tritko, you take your hand down? Looks like you took your hand down there. I'll just make sure I didn't miss anything there. Nope, you're good? Oh, okay, go for it. Dr. Tritko.
Well, I don't know which one we're talking about, but slide 1 where it talks about universal healthcare means all Washington residents can access essential, effective, and rather than appropriate, I would put affordable. I realize you come back and kind of get to that, but affordability is one of the primary problems that we have today in healthcare.
Okay. So Dr. Tritko is referring to that synthesis statement that we had earlier, and I'll just pop that back on the screen again so folks can see it. This statement right here. So he's saying that he wants to make sure that affordable is emphasized here, and I think you suggested actually removing appropriate and saying affordable. Did I hear that correctly? You just give me a thumbs up if I have that right. Okay. All right. I'm going to take it back to this question here about this goal right here, system that provides all Washingtonians with full access to comprehensive, essential, equitable, effective, and appropriate health services that are affordable to everyone. Because I think the point about affordable is also captured here. And I want to check in with our group here and see, I'm going to stop share, and see if anyone has feedback on this goal. Representative Schmidt, I saw you just sent me a comment about it. Do you want me to just read that, or do you want to share your thoughts there?
Oh, I can talk. All those things
Yes,
defined by whom? Essential, effective, and those things.
I'm not sure if I'm understanding your question, so I might ask you to elaborate there. Do you mean in terms of where did that language come from? Here, I'll help you unmute there.
Can you hear me now?
I can,
okay.
Yes.
Essential, effective, affordable, all those are very nebulous terms. How do you define them, and who is going to define them?
Okay. All right. So with respect to how those are defined, I know this was way back when, so some of you may have forgotten about it. I certainly have. But back in December, we actually put together a document that pretty thoroughly summarizes what folks meant by each of these terms. So I'm going to refer everyone back to that. Maybe you can take a look after the meeting. With respect to who is going to define that, I think that's probably, I don't want to answer that actually. I think that's a question I'd like to punt to our other work group members. From your perspective, who would answer that question of how we define effective, essential? Any thoughts there? think we've got a quiet group today. Why don't we put a pin in that question? I want to make sure we oh, yeah, Dennis. Let me unmute you here. You be able to unmute? We'll try one more time. Yikes. Hold on. Let's see if we can get you unmuted.
Okay.
There we go.
Okay. Those are things that are more or less just statements. Usually it's the doctor that decides what's the effective, appropriate coverage. We're not going to have lay people do that. We're going to have the doctors be able to make that decision. And unless it's challenged and then reasonably challenged, the doctor would have the authority, which everybody wants, to determine what is effective, what is good for their patient that they have examined, that they have determined needs that particular benefit. To require someone else, like some scientist or some legislator or some group of people decide that, I think would be inappropriate. It's difficult, but the doctor has to be the one. If the insurance company, if that's who it is, or if the state decides that they shouldn't cover it because it's innovative or scientifically inappropriate, then they can challenge that, but it should be very limited.
Thanks, Dennis. I see Pam's hand up, and also if folks have feedback on what Dennis just shared, I'd love to hear that too. Pam, let me give this unmuting a shot here. There we go.
There, I'm unmuted. When we passed the law in the 90s, we had a commission that decided those things. And then under the Affordable Care Act, the law spells out, for example, the benefits, like what is considered an essential benefit was defined by the insurance commissioner. So I agree with Representative Schmick that someone does need to define these things. And if the federal government pays or the state pays, then that will somehow be decided by the payers. So these things have been done, by commissions, by boards. You decide someone. They're definitely interpreted by doctors, but doctors also, if they want to get paid, they have to know what the rules are and what's allowed and not allowed in terms of charges. So ultimately, there does need to be some kind of governing body.
So I want to make sure I take us back to the original question, which is around what, if anything, needs to be changed by this goal. And I think the question Representative Schmick raised is the way that we might bring it back to this particular question is that the goal that we outlined, we should be clear somewhere about how those things are defined. I hear Dennis saying that the system needs to be designed so the doctor ultimately has the authority to decide what's effective and appropriate. And I hear Pam saying that there needs to be some boundaries or swim lanes or envelope that the doctor works within, and that's usually decided by some kind of government commission or group of experts. Did I hear that correctly? Did I miss anything there? Dr. Trick, I'll come back to you in just a moment. I just want to clear the things up. So Dennis, go ahead.
Yeah, no, Pam is right that the legislature decided what the benefit package would be. Then the commission was given the responsibility of trying to make those limits more usable because we were having trouble about when insurance companies should cover chiropractic or acupuncture or some other types of coverage that many insurance companies didn't want to cover. But again, you do the outlines to saying that this benefit, mental health, let's say, that mental health needs to be covered. But who decides what this particular patient needs is going to be the doctor. But if mental health is covered, you're not going to put in there that only these particular things in that area would be covered. You give the doctor some pretty broad authority to determine what he should provide under that authorization of mental health care or childbirth or something like that. Each one has a broad base. But Pam's right. We gave it to the commission to decide an awful lot of things that we weren't able to decide. But still, the doctors are the ones that have the final decision to make as effectively carrying out the benefit package.
Great. And we can talk a little bit more about how that might be done when we get to our transition discussion later. Dr. Tritko, you've been waiting patiently.
I wish what Representative Delwo said was true. It's certainly the Affordable Care Act allows the state to determine what are essential health benefits, and those are broad categories. When it comes to actually performing the services, the way they are deemed to be, whether they're essential or effective or covered, is coding combinations. So there's roughly 6,000 CPT codes, 100,000 ICD codes. It's those coding combinations that have been developed ever since the fee schedule came out in 1992 that determines whether it will be covered. If it's not covered, it's not likely going to be offered. And that's why going forward, when we look at Model A, to reinvent that entire system is nearly impossible. We need health plans at least to administer the plans because they already have developed rules that people are using today. And to start from scratch with a Model A would just be almost impossible.
Thank you. Okay, folks, I'm going to try to move us along. We get a little echo there. I'm going to try to move us along a little bit here because we've got several other goals we want to cover. And I think I don't want to get us too bogged down into what's the actual mechanics of defining what's essential and effective. But suffice it to say, we're taking down your feedback on this. Before we move on to the next goal, are there any, are folks comfortable with this concept, or are there any concerns about how we've articulated the goal? And Nora helpfully put it in the chat so you can reference back. I'll just remind you, a system that provides all Washingtonians with full access to comprehensive, essential, equitable, effective, and appropriate health services that are affordable to everyone. Any additional feedback before we move on to the next goal? All right, I'm going to take us to equity then. I'm going to put that on the screen. All right, so the equity goal here, the goal is articulated like this: the system that promotes equity in access to quality care across race, ethnicity, culture, income, language, geography, gender, and other differences to reduce variance in the delivery of care and health outcomes. And hopefully you had a chance to read what this means, but ensuring consistency in healthcare delivery in rural areas and across races, ethnicities, language groups, and other types of communities, encourages culturally responsive care, and encourages transparency of healthcare quality, including reporting of adverse effects. So Nora, do you mind dropping that in the chat again? That was really helpful. And I'm going to stop share and come back to our group here. What's your feedback on this goal? Is there anything that you think should be changed, adjusted? Do you have questions or confusion about any of it? I'm going to pick on some of our folks who haven't spoken yet. Shirley Prasad, what about you? Do you have any feedback on this one? Oh, I need to unmute you here. You want to?
Here, does that work? Okay, perfect.
Yeah,
I think this is a pretty good list to kind of encapsulate under this umbrella. I wonder though if a group that is missing from this, I'm trying to see if they would fit into any of this, individuals who are visually or impaired or hearing impaired, in terms of encapsulating equity for those populations.
Okay, so it sounds like it's specific, just hearing and visual, or are you thinking more in terms of, I don't think we list mobility here or living with disabilities. Were you thinking of encapsulating all of that, or is this specific to hearing and visual?
I think that, well, I mean, I'd be curious to hear if others have thoughts too. I mean, I think that, yeah, if we wanted to include disabilities as kind of that broader umbrella, that could work in here.
Okay. Others have feedback here? I'm going to start picking on you if you don't raise your hand. Okay, I think someone doesn't have their mute button on. I'm hearing some typing in the background. If everyone could mute, that would be great. Let's see. Brenda, how about you? Do you have any thoughts on this one?
I mean, no. Not particularly. I agree with what Shirley said. I think it's good to have the larger, broader terminology there, and not just call out one or, specific challenges. Other than that, I think it's good. I mean, it seems pretty comprehensive to me.
Okay. I'm going to try to put the question in a slightly different way. If this is in our report, are there any caveats or concerns that anyone would want us to articulate or document? Or does this particular goal feel right to folks? Dr. Tritko.
The problem that we have today in this is the goal is correct to reduce variability. The problem that we have is accessing